Life is precious. It's meant to be savoured, cherished, and enjoyed. But for many women, when perimenopause and menopause hit, something shifts. That spark, that joie de vivre, that vest for life, it starts to fade. And for some, it's a slow decline. For others, it's like a switch has been flipped overnight. Suddenly, you're just existing, emotionless, numb, exhausted. So, what's the solution? Too often, women walk out of a 15-minute doctor's appointment with a prescription for antidepressants. Could the real answer lie in testosterone? Today, we're thrilled to welcome Dr. Louise Newson, menopause royalty. She's one of the most respected voices in menopause health, and she's here to help us understand why testosterone is essential for women, how a simple gel or cream could restore your energy, your mood, your libido, and the science backed benefits and safety of testosterone. So grab a cuppa, settle in. This episode might just change your life. Dr. Louise Newson. How
Oh,
wonderful to have you with us.
well, thanks for inviting me. It's great to be here.
This is a topic that keeps popping up. I've spoken to many experts across the world, whether they be, surgeons or holistic medical people, and yet testosterone. It's this word we haven't narrowed down on until today. You've worked with countless clients over the years. Does this story sound familiar? Is testosterone
Yeah,
missing from our puzzle?
it often is. Obviously, it's not the only missing puzzle for many of us, but what's really frustrating even for me as a doctor is that if I'd met you probably 10, 12 years ago, I would have said to you, now this is really embarrassing, but I would have said to you, I don't think women have testosterone. That's the male hormone, isn't it? And so a lot of it has become from misinformation, actually. I've also got a pathology degree as well as a medicine degree, and I'm very interested in basic science because pathology is the study of disease. So you have to know how the body works, because then when it has disease, you understand what's going on in a molecular and a cellular way. And so when I first went to a lecture, actually, by a menopause specialist about 10 years ago, he talked about testosterone in women. And I was like, what's that? Why? I don't understand. So I went back to basic physiology books and thought, gosh, this is so fascinating. Testosterone is produced by women. It's the most biologically active hormone that we have. Levels of testosterone are greater than levels of estrogen when we're younger, and levels decline with age. And then I thought, well, is it an ovarian hormone? Because we always think menopause is ovaries, but actually only about half of our testosterone is made in our ovaries. So then people think, well, where's the rest? Well, our adrenal glands, but also our brain produces it as well. So it's a really key hormone. And even in the 1940s, they were doing research in men and women on testosterone. But then women, like for many things, they forgot about women and testosterone, and the studies and the research and the money was all made in male testosterone products. So it feels like this is long overdue conversation, actually. But now, fast forward all those years, I know a lot about testosterone in the way it works, but also I have a huge amount of clinical knowledge and experience. And as a doctor, medicine's a science and an art. You learn the science, and then the art is individualizing care and learning from patients, which is what I've done, in a huge scale actually over the last 8 years.
So you learned that testosterone matters in every part of our body. It obviously affects our brains, it affects our
Mm,
circulation and our cardiovascular
mm,
health, obviously our
mm,
libido and our pleasure,
mm,
muscles,
mm.
bones, bladder, pelvic floor, eyes, skin. It
Yeah.
affects every single cell, as you say.
Yeah, so we've got receptors that respond to testosterone in every cell of our body. And if you think of, it's very simplistic, but if you think of a key and lock, the lock is the receptor on the cell, and the key is a hormone. And a hormone is a chemical messenger. That's all it is, that goes in the bloodstream and then works around our blood and gets to every cell in our body. So then we have testosterone receptors, and testosterone is the key. And so all we're doing is putting the key in the lock and then unlocking these amazing cellular processes that occur. So, of course, our body will work without a hormone, but it's not going to work as effectively. And many women have symptoms, like you say, but also it has benefits for the way that our bodies work, like our muscles, our bones, our heart, our brain, and so forth as well.
So when you say that it starts to decline, at what
Mm.
age does it start to decline?
So, I mean, everyone's
Mm.
different, of course, and that's what sometimes we forget in science, that everyone is individual. But on average, in the late 20s, early 30s, testosterone levels start to decline. Now, some women actually, they have a little bit of an uptick as they get older, but most people, does decline with age. So it's more of an age-related decline rather than a menopause-related decline. Now, if I was young and had my ovaries removed, I would clearly lose 50% of my testosterone
Mhm.
overnight. So, women who have a surgical menopause, or if they have a medical menopause, maybe they've had chemotherapy, drugs for cancer, stops their ovaries working, their testosterone level will decline very
Mhm.
quickly. But most of us, it's an age related thing. And increasingly in our clinic, I see women who have regular periods, so they're still producing estrogen and progesterone, but they come in and they've got low mood, reduced motivation, muscle and joint pain, poor energy. Like you say, that sort of zest for life
Mhm.
has gone. They just feel like they're existing, not living, and they've got zero libido. And I do their testosterone level, which is a useful guide, and it's very low. Giving them back testosterone absolutely, transforms some of these women. But it's been forgotten for so long. And like you say, sadly, it's easier to get antidepressants
Mm.
than it is to get testosterone prescription.
Imagine this, unlocking your genetic blueprint with insights from over 200 healthy aging genes, pinpointing your unique SNPs and potential red flags, understanding what your body needs to thrive and where it may need some extra support. No more guesswork, no more random supplements, one off blood tests, or one size fits all advice. For the first time in history, we have access to the power of genetic testing, something no generation before us has had. This information could change everything. Join our free DNA webinar and you'll get our Stay Well scorecard jam packed with the markers that we want you to track every year, starting now. Friends, know your genes, own your health. Let's learn to thrive together. Visit theagingproject.com to register, and I'll see you there. Would it be really strange for a woman in their 20s or 30s to go to their GP and say, hey, I'm young. I'm obviously not in perimenopause yet, hopefully. I know there is early onsets, but I have these things. I've got the mood swings and I've got anxiety and my muscles just don't feel right. And I've got urinary issues.
Mm.
Have you thought of testosterone? Like, would that be a strange thing now for someone to
You
ask
know,
about?
You know what? I don't think it would be, because it shows that woman's really empowered and thinking about her health. What is frustrating is that doctors often aren't educated adequately, and they don't have enough experience in testosterone, so they will probably be pushed back and say, "Oh no, it's a male hormone. You don't want to take that." And in the Australia, you're very lucky because you have a licensed testosterone product, but it's less than 1% of women are prescribed testosterone, whereas I don't know what your figures are in Australia, but it's probably around 20% of women are prescribed
Mm.
antidepressants. So there's a big difference. The other thing with younger women, as you might know, is women who take the contraceptive pill, so the combined oral contraceptive pill. What it does is it increases something called sex hormone binding globulin, which actually reduces freely available testosterone in the body. It binds to testosterone, so it's not available to get into those nice locks on the cells, the receptors. And so a lot of people go on the contraceptive pill and then they feel quite flat and joyless, and then they get antidepressants. And actually, a lot of those women would probably benefit from some add back testosterone just to replace that missing testosterone. Um, in medicine, we don't always have the right
Mm.
answer, but often what we do is we try a medication and see if it helps. So often, especially with the younger people, I'll say, look, your testosterone blood test is low. You've got these symptoms suggestive of testosterone deficiency, but actually, I don't know whether your symptoms are due to that or something
Mhm.
else. But if I give you testosterone for a few
Mhm.
months, we'll measure your level again and let's see what happens. And that's not unreasonable to do, but there's this real resistance actually for testosterone. People often are very scared of perceived side effects. people are worried because we don't have, the right evidence, because most of the studies have been done on libido. But lack of evidence doesn't mean that we can't try a natural physiological hormone.
Well, what are some of those side effects? Because I'm imagining that I'll start growing a beard, that I'll get
Yeah.
a particularly deep voice. What is testosterone
Yeah.
therapy
So,
or gel
so
gonna bring?
Yeah. So there's two things really when we think about this. The first thing is there are different types of testosterone, like there are different types of estrogen and progesterone. Some of people might have heard me talk about before about the natural body identical hormones and synthetic hormones. Now, when they were marketing testosterone in the 1940s, many years ago, they made it synthetic, so they've chemically altered it so they could get it to market. But that meant it didn't go in the receptors the same way. It was a bit like a dodgy key that you get cut. It goes into the receptor, it doesn't unlock. When probably most of us had a key, you put it in the door, I think great, and then you can't unlock it. So it blocks the receptors, so it means it doesn't have the same biological effects. So synthetic testosterones have more risks, the same way that synthetic estrogen and progesterone have risks. So when people talk about risks of heart disease, risks of blood disorders, it will be related to the synthetic testosterone. Now, we've got testosterone as a cream and gel that's natural. So under the microscope, it looks exactly the same as our natural testosterone. We're replacing like for like. So that's one thing people have to be really careful when they're talking about testosterone. Testosterone, people talk about it being an anabolic steroid. It will really build up muscles. Yes, if you take the synthetic testosterone. So lots of people who, well, not lots, but some people who go to gyms, they're injecting testosterone. That is not the natural testosterone. So I only prescribe the natural testosterone, either the gel or the cream. So the side effects or the risks are not there. So that's really important for people to know. And then if it's prescribed at the right dose to the right person, the risk of side effects is incredibly low. I've been using testosterone for 8 years. I never shave my face. I don't have bearded patients. But I prescribe the right dose. Blood tests are a guide to see. Some people need more, some people need less. The commonest side effect is that at the site of application, and we normally apply it onto our thigh, is that you can get some hair growth because it will stimulate the hair follicles where you're rubbing it in. But for most of us, if our brain is working, we don't really mind about a slight bit of hair on our thigh. Some people worry about acne. Some people who are prone to acne, like when they were teenagers, might find that they have some acne coming back because it's giving them back the hormones they had as a teenager. But a lot of women deal with their skin and continue with the testosterone because they feel better. Voice changes are really, really rare. I've got one lady who had some voice changes, but she'd actually bought testosterone online and was using a far greater dose. But when she came down to her dose needed for her voice came back to normal. Some people talk about clitoromegaly, the enlargement of the clitoris. And again, I've never seen it in a pathological way. A lot of people actually find that without hormones, especially testosterone, the clitoris actually shrinks. So then it can come back to its normal size, which actually most women quite enjoy and like. So we can't be too derogatory to women worrying too much about that. And the other thing is side effects are reversible. Testosterone is a very short-acting hormone, so it doesn't last very long in the body. So if women stop their testosterone, their symptom improvement will go quite quickly, but also any side effects will usually disappear.
Interesting. So you're going to know pretty much straight away whether it's having a positive effect on you as
Yeah,
well.
yeah, yeah. Often, I mean, it can take a few months when people start. Another side effect that sometimes people get, especially in those women who have very low testosterone, when they start, they can feel a bit wired, a bit sort of, sometimes people feel a bit agitated, a bit irritable. And that's almost like, it's a bit like, I always explain to patients, it's a bit like a really dry sponge. If you put some water on a dry sponge, it sort of just absorbs that water very, very quickly. And so I think it sounds a bit simplistic, but it's almost like the brain's going, wow, gosh, actually, this is a bit much for me because I've not had testosterone for a while. And for those women, we usually just say, look, start at a really, really low dose, like a tiny bit, and then gradually increase over the next few months, and then the body adjusts. But it can take 3 to 6 months to have an effect. And then actually often what happens is that we'll do a blood test and see if the dose needs adjusting. So if someone comes to me the blood level's low, they try it, and if they don't feel any better and their their testosterone's still low, then I might increase the dose rather than saying it's not worked for you.
We know when we have blood tests, and often it depends, on the time of the month, the time of the day, what we had for breakfast, when we did this. Is a testosterone blood test similar? Is there a better time to test what your levels really are?
Yeah, no, not really. And different laboratories do testing in different ways, so it can be it's very crude test really. We do something called the sex hormone binding globulin as well as testosterone. So we work out what's called the free androgen index, which gives us a guide. But a lot of blood tests in medicine are a guide. You know, if I did someone's blood test 8 times in a day, I would get 8 different results. So it's really in clinical context. You know, any investigation in medicine, you have to be considered in front of the patient because we're all different. We don't always do blood tests on everything we prescribe for in medicine. Like antidepressants, no one does a blood test looking at serotonin levels. You know, we don't always have to, but in testosterone prescribing, it's just a useful test to have, if you see what I mean. We sometimes see people who are on testosterone and their level comes back raised and everyone really panics, but the patient's feeling great with no side effects at all. And then often we repeat it and the blood level's normal again. You know, especially if someone's used testosterone on the day of the blood test, and they might have got dressed and then dragged their hand up maybe on their arm, and then they have the needle going through where there's some testosterone floating around. So, you know, it is very crude. What is in our blood is not the same as what's in our brain and our tissues as well. So again, we're just all different and we vary so much.
A quick break in today's conversation, and I know you'll be interested in this one. In my chat with Dr. Lara Bryden, we learned inositol is one of her favourite safe and inexpensive supplements to improve insulin resistance and aid weight loss. She also spoke of the benefits for PCOS sufferers. In the podcast conversation, Dr. Bryden told us inositol has been researched for women in perimenopause and menopause for insulin resistance and been clinically trialled and found to be effective, and is one of 5 missing metabolic nutrients that women need. This is the reason why we've always stocked inositol over at youmusttryit.com. So ladies, if you're worried about abdominal visceral fat, search for inositol over at youmusttryit.com before they get snapped up. And the chances are, I guess, if you're in the perimenopause age group, if you're having any of these signs or symptoms, if you've thought about HRT, perhaps testosterone along with that, testosterone therapy is a good option or something to ask the question.
Yeah, absolutely. A lot of people find that testosterone really is the icing on the cake. You know, a lot of people feel a bit better on estrogen and progesterone, but it's not until testosterone's added they just feel like their brain has come alive again. And I know, sort of personally speaking, you know, I wouldn't be working as a doctor if I wasn't taking testosterone. It's helped my sleep, it's helped my migraines, it's helped muscle and joint pain. It's just given me that clarity of thought, that ability to multitask and to stay really focused on points and just to be able to use my brain. Some of your listeners might be experiencing brain fog, and it's the most scary symptom actually, where you know that you've got something in your brain that you should be able to either say or remember, and you just can't. This word finding ability is very difficult. It really is that thinking through treacle. It's really hard, and so many women come to us and say, I'm just so scared I've got dementia. I can't work because I can't think. I can't concentrate. I am just existing. I'm not living. I'm not enjoying my life. A lot of them have had antidepressants and say, well, the antidepressants have just numbed me, but I don't want to stop them because I don't want to feel worse. And then we also see quite a few people actually in our clinic who've come from psychiatric clinics or even hospitals. Many years they've had really awful symptoms, and it's not until they have testosterone that it's really transformational. And I've seen it time and time again. Women who have been on lithium, quetiapine, olanzapine, heavy duty drugs, as well as antidepressants, and giving them the testosterone often is just a game changer for their mental health. So we can't be ignoring it and keep saying, well, we haven't got enough evidence, because It's a natural hormone. It's very different if I was prescribing a drug, a chemical that's not
Yes.
made for our body. Of course, we have to try and have as much evidence as possible, but actually, a lot of things in medicine have very poor sort of studies and evidence behind them. A lot of it is learned in clinical experience,
Oh
actually.
my God, bring it on, I say, Louise. This
Mm.
sounds it sounds magical. It sounds
I mean,
wonderful.
the other thing is that, taking testosterone should be a
Mhm.
choice. You know, I'm an individual woman, I'm a menopausal woman. I surely, age 54, can decide whether I want to try testosterone or not. So I'm not here saying everyone has to have
Mhm.
it. I'm not here saying everyone has to do yoga. Like, it's up to them. But what I hear time and time again is that women are being told they can't have
Mm.
it. And that really saddens me. And a lot of people, the guidelines say we can add it on if people have reduced libido. Now, most women at some stage of their lives will have reduced libido, but then some menopause societies say women have to have hypoactive sexual desire disorder, which is HSDD. And if you look at the criteria for it, it's quite stressing actually
Mm.
for me as a doctor, but also for women, because one of the criteria is that women have to be severely psychologically distressed with their reduced libido for at least 6 months. Now, I went into medicine to help
Mm.
people feel better. I did not go into medicine to watch people become severely psychologically distressed with any symptom for at least 6 months. It's a very, and there are other things listed in the criteria, and I feel that's really sad to be judging someone and scrutinizing
Mm.
them really into great depths and detail about their libido, because some women don't have partners, and I've spoken to a lot of women who are told by their doctor, look, you haven't got a partner,
Don't worry
therefore
about it.
libido is not
Yeah, doesn't
important
count,
for you.
does it?
And again, I think this is comes to sort of a justice type
Mm.
decision. It is a justice. We are allowed to choose something, and like I say, it's just our own hormone. Like, I don't really understand the big concern
That's it.
about
If
it, to be
if you
honest.
if you're old enough to get a tattoo and drink a tequila, surely you're old enough to ask about testosterone.
Yeah.
That's madness. Okay, so an absolute novice here, but I'm assuming when you talk about brain fog, which is something that we also call baby brain,
Mm,
when you are pregnant or have a
mm.
child and you're breastfeeding, what are your testosterone levels then? Could that have anything to do with baby brain and the brain
Yeah,
fog you have then?
yeah, for sure. I mean, when we're pregnant, our hormones, estrogen, progesterone, and testosterone become very high, like thousands, a lot higher than they are at any other time of our lives. And often, many of us feel great when we're
Oh, and we
pregnant.
come up with
And
crazy
then,
business ideas and launch
yeah, for
products and
sure,
do
because
all sorts of
yeah,
madness.
our brains are fired, and then suddenly overnight, the hormone levels decline, and it's quite frustrating, isn't it? I've had 3 pregnancies. I've got 3 daughters, and each time the midwives say, "Oh, you'll get baby blues. You're going to find, when your milk comes in, you'll feel really low. You might get some night sweats. You might get some vaginal dryness and soreness." And I sort of did, and I just expected it, but I never thought, oh, that graph of my hormones falling off a cliff, maybe that's associated. Maybe if I just took some really low dose hormones, I would feel a lot better. And I had my third daughter when I was 40. I started HRT and testosterone when I was 45, 46, and I just wish I'd taken testosterone probably 10 years
Mm.
before. I bet I was testosterone deficient for quite a long time, but I didn't think about it. I didn't know about it, like I said. So,
This is fascinating, and I'm so thrilled that we're living in this time and we're a generation of women that don't hold back, and we've been
yeah.
told we can do it all and have it all, and we really are giving it a red hot go. And the fact that we're
Mm.
having these conversations in the first place is testament to women like you that are leading the way and speaking loudly about what they have learnt and where science is going, and the fact that even the science is bringing us back to natural remedies or natural
Mm.
options is fabulous. I guess this is biohacking, isn't it? If we're adding testosterone to our system and we're adding estrogen to our system and progesterone to our system, why doesn't the perimenopause journey just stop? How come we still will hit menopause, even if we are doing all these things to boost our hormones?
Yeah, so I mean, if we think about what menopause is, because it causes a lot of confusion for a lot of people, menopause basically, when you break down the word, means stop of periods, but it has actually been defined as a year since our last period, which is really like maddening, isn't it? Like, why a year? Who decided and what
Well, the
happened?
same
But
people that decide so many things that it was just it
yeah,
sounded like a good
precisely.
number, yeah?
I know, but also lots of women don't have periods. If you've had a hysterectomy, you've had your womb removed, you'll never have a period again. Like, how do you become menopausal? So, thinking what it is when our ovaries usually stop
Mhm.
working, usually because we age. We've only got a finite number of eggs in our ovaries, but it's some people, like I said before, if your ovaries are damaged or you take drugs or whatever, your ovaries aren't going to work. So you might have a forced menopause, really. So, but I've already said our hormones aren't just from our ovaries, they're from elsewhere as well. So when those levels decline, they stay low forever.
Mhm.
And this forever bit is really relevant now in 2025. Like 100 years ago, women didn't live as long. They actually often had a natural menopause at an older age, and that's probably partly because they had so many pregnancies
Mhm.
often, so their ovaries were more conserved. When you're pregnant for 9 months, you're not releasing an egg every
Mhm.
month, are you? So women had a tend to have an older menopause age, and then they died quite soon after. Whereas now, fast forward 100 years, we are living a lot longer. Our life expectancy is a lot longer. But actually, as women, often our last 10 years of our life are in quite poor health because of diseases. And this is where, like I said at the beginning, our hormones, not just testosterone, but estrogen and progesterone, have very important anti inflammatory effects in our cells, in our bodies. They help our bodies to function. So if we don't have them, we have increased inflammation, increased risk of heart disease, osteoporosis, diabetes, dementia, cancers, earlier death. And that can catch up with a lot of women. And so a lot of women have poor health as they
Mm.
age. I'm very interested as a doctor to prevent disease, and we need to be thinking about this health
Mhm.
span, not just lifespan. So it's not the age we die, it's the journey to that age. It's keeping healthy as long as possible. So it makes sense that we're replacing those hormones. Some people think, well, it's meddling with nature, but we meddle with nature all the time as doctors. People have raised blood pressure as they age often. We treat raised blood pressure to reduce the risk of a heart attack or
Mhm.
stroke. Now, taking hormones will reduce the risk of having a heart attack better than actually taking an antihypertensive. So we need to sort of have a bit of a mind shift, really, thinking about why are we so scared of hormones
Mm.
that are natural, that have important effects to improve symptoms, but also to improve our future health
Mhm.
as well. Because, we all want to age well.
Louise, on behalf of the Aging Project community, 1,000 thank yous for today's conversation. Friends, I know that this has helped fill in so many of the blanks about testosterone. For me, it's filled a massive gaping hole because before today, I knew close to nothing about this really important topic. This is one of those episodes we really hope that you will share far and wide with women of all ages, whether they're planning a family, navigating perimenopause, or living through menopause. This information matters. If testosterone can help women's brains come back alive, reduce brain fog, spark more joy, and even support future health, then this is a message we all need to hear because it's about making informed decisions for our own well-being. At the start of today's conversation, I said that this chat could be life-changing, and for many, I truly believe that it will be. Before I go, I want to mention that inside the Fit Genes program, you'll receive the fertility report. This matters because, as Dr. Louise pointed out, we're also different, and that difference begins at a genetic level. For me, this report has been eye-opening. It revealed that I have SNPs linked to a higher risk of low testosterone, as well as SNPs related to important vitamins like zinc and choline. I'm using my results as a roadmap to focus on what my body needs. And let me tell you, after today's chat, testosterone is now an even bigger priority for me. If you're curious about your own genetic blueprint, whether you're thinking about starting a family, navigating perimenopause, or wanting to take charge of your own long-term health, knowing your genes really is the best first step. The links are in the show notes. Otherwise, you can visit theagingproject.com. Join our free DNA webinar to discover how your unique genetics can guide your choices. Here's to less brain fog, more joy, and dare we say it, more testosterone. Thank you so much for listening, friends. Stay well. We'll talk again soon. As always, the Aging Project podcast is for educational and entertainment purposes. Always seek medical advice from a qualified practitioner.